Grandma Clemens in the summer of 2013. She was diagnosed with bladder cancer. They found it by going to her urologist for frequent visits and for constant UTIs. This is her granddaughter. She's my roommate, and she told me it was okay to use this. She first started off with a chemo treatment, but it made her too sick, and the family urged the doctors to switch. They put her on mitomycin and Xylda. The doctors didn't want to change her because she's an 84-year-old woman, and they thought it was too risky. They were giving it to her peripherally through an IV, and this is the result. She got an infiltration, and it damaged her arm. She told the nurse that she felt like it was leaking into her peripheral veins, and the nurse looked at it and didn't check it out further. She's had multiple surgeries since then and debridements, and it started to get better, and this is where it's at now.
The most common type of bladder cancer is transitional cell carcinoma. The cancer starts in the epithelium of the bladder. Being the innermost layer, most of the symptoms have to involve the process of urination or the urine itself, such as hematuria, pain and burning upon urination, and an increase in frequency. The standard treatment is surgical removal of any superficial tumors followed by intravesical drug therapy. One of the most common drugs that is given is mitomycin C. Typically, these drugs are given directly into the bladder to reduce the risk of tumor reoccurrence, though in Miss Grandma Clemens' case, the choice was made to give the drugs peripherally, leading to the medical error that resulted in irreversible damage.
Each hospital and outpatient clinic that administers oral and parenteral chemotherapy follows a strict set of protocols and guidelines while doing so. According to their website, Marquis Cancer Center has selected to follow guidelines and practice recommendations set forth by the American Society of Clinical Oncology. They say for administration of parenteral chemotherapy, the ASCO recommends for chemotherapy administration, the nurse who is administering the chemotherapy confirms with the patient his or her planned treatment prior to each cycle. Then at least 2 practitioners or personnel approved by the practice or institution prepare or administer the chemotherapy, verify the accuracy of the drug name, the drug dose, the drug volume, the rate of administration, the expiration dates, appearance and physical integrity of the drugs, and the rate set on the infusion pump when utilized. The nurse who is administering the chemotherapy documents that verification in the previous part was done. At least 2 individuals in the presence of the patient verify the patient identification using at least 2 identifiers, like their medical record number or their date of birth. Extravasation management procedures are defined and aligned with the current literature and guidelines. The antidote orders are set, and antidotes are accessible during the time of infusion. The most important part is that the appropriately licensed practitioner must be on site for the initiation of first doses of parenteral chemotherapy and should remain readily available for the patient throughout the entire administration of the chemotherapy. This practitioner must be knowledgeable of responses to life-threatening emergencies and be able to implement antidotes when needed.
In the case of Grandma Clemens, there were several risk factors and system errors that played into the extravasation that caused the permanent damage to her arm, and we're going to talk about a few of those. Risk factors for extravasation include small or fragile veins, hard and or sclerosed veins, as might be seen in a patient who's had several rounds of chemotherapy, prominent but mobile veins, as are often seen in the elderly, known disease states which impair circulation and sensation, such as peripheral artery disease and diabetes, predisposition to bleeding and or anticoagulant therapies, communication difficulties which hinder early reporting, which may include aphasia from strokes, prolonged infusions, and obesity, which make veins harder to find. Minimizing the risk of extravasation, it's very important that the nurses have proper training. All staff involved in the management and infusion of cytotoxic drugs must be specially trained. Training should include not only how to safely and effectively administer these medications, but also how to respond to adverse outcomes such as extravasation. Minimizing the risk also includes access placement. Correct placement of the IV access is vital to ensure that extravasation does not happen. Identification of the most appropriate cannulation site should be undertaken before insertion. Large veins in the forearm are recommended for peripheral administration and cannulation over joints. The inner wrist and the lower extremity should be avoided, and veins in the cubital space or the dorsum of the hand are not recommended for vesicant drug administration. Also, it's very important to choose the right equipment. The type of equipment selected to gain access is very important. Winged steel infusion devices or butterfly-tipped needles should not be used because they can easily be displaced and puncture through the venous wall. Instead, flexible cannulas should be used. The golden standard, however, still remains the central venous access device, which will be discussed later. Most vital of all, however, is monitoring, and this is really where the system failed Grandma Clemens. Finally, after cannulation, you should check for blood flow and then flush with 10 milliliters of normal saline and check for signs of infiltration or extravasation. Flushing with 10 to 20 milliliters of saline, as well as an additional check for blood return, should be performed between each different drug infusion when the infusions are changed or a new drug is started. Most importantly, the insertion site should be monitored for signs and symptoms of extravasation, such as swelling, pain, redness, slowing of the infusion rate, and the site needs to be assessed every hour. In the case of Grandma Clemens, she expressed that the site did not feel correct, and yet the nurse did not come back and reassess the site. So what do you do when extravasation does occur? The European Society for Medical Oncology and the European Oncology Nurses Society have some clinical practice guidelines for the management of chemotherapy extravasation that are widely recognized as being the gold standard. So when extravasation occurs, you need to stop and disconnect the infusion. Leave the needle in place. Identify the extravasized agent. Leaving the cannula in place, gently try to aspirate as much of the solution as possible. Record the volume that you removed in patient records. Avoid manual pressure over the extravasated area. This, in the case of Grandma Clemens, was not done and most likely led to a furthering of the extravasation fluid in the tissue. Then you should remove the cannula. Mark with a pen the outline of the extravasated area. Notify the physician. Start specific measures as soon as possible. For vesicants and irritants such as the mitomycin that Grandma Clemens was on, localize and neutralize. To localize, apply cold, dry compresses for 20 minutes, 4 times daily for 1 to 2 days, and avoid alcohol compresses, helping to localize the extravagant agent in the skin. Neutralize. Use specific antidotes. In the case of mitomycin, administer topical DMSO. Also, elevate the limb and then administer analgesics if necessary. Following these steps will help to prevent further damage to the limb. So we interviewed a chemotherapy nurse for her take on Mrs. Clemens' situation. Thank you for being with us today.
No problem.
What is your typical workload like? If you could, please describe a typical work day for you.
My role has changed so much because cancer care has changed. Most chemo is given outpatient now, and most of it is IV piggyback. Soon we'll be seeing many oral agents, which can just be as toxic. They have challenges like compliance and proper patient administration. Regarding my workload, a typical day, it changes depending on what MD's clinic I'm working with and what type of malignancy that they specialize in. A nurse will have typically 4 to 8 patients depending on the patient acuity and the chemo load. Many and most of the treatment protocols require monitoring due to the potential hypersensitivity reactions. We spend a lot of time addressing chemotoxicity like dehydration, nausea, infection, and platelet and red blood cell depletion. We also perform many bone marrow biopsies and some thoracentesis and paracentesis.
We've talked to you about Mrs. Clemens and you've reviewed her case files. What do you think may have led to the error in this case?
If I recall, there was multiple necrosis down to the bone, and I believe multiple plastics interventions were necessary. I believe mitomycin was the agent, and the issue of extravasation and chemotherapy is always one of the dreaded ones in my field.
At your particular place of work, are there any policies in relation to chemo being administered in a peripheral IV, especially considering some recommendations want chemo administered solely in a central venous device?
There are definite policies in place regarding the correct and safest way to administer these drugs called vesicants, both peripherally and centrally. Firstly, best practice is to have a portacath or a central line available, but sometimes that's not possible or the patient declines, but the central access is safest. Our policy for peripheral administration calls for the following things. 1, a consigned cent for each named chemo. The nurse giving the drug starts the IV, and she will know if it was a clean stick or if it may have been compromised. Blood return is confirmed with normal saline and is maintained throughout the peripheral injection. Monitored 1 to 2 mL of drug using a tourniquet as needed. A normal saline flush drip is maintained. The chemo is given at the closest Y site. The patient, if alert, is asked to verbalize immediately if there's any discomfort, pain, or burning related to the IV. Stop the IV if the pain or swelling occurs and try to extract or pull back on any possible drug. Leave the IV in place in case of any steroids are recommended. Call the MD for suspected or actual extravasation. Alert the pharmacy. There are different treatments and different agents to minimize and counteract the damage, but for the most part, drug prevention is key. If the patient has a central line, you must confirm the integrity of the line with a blood return before starting with 3 to 5 mL of the drug. Always ask the patient to report any discomfort, especially with women with breast tissue, that can move to displace the Huber needle from the port. If not sure that the needle is in the right place of the port or leaking, do a port study in radiology. In some ports, you'll see a fibrin flap on the end of the catheter and you will not get a blood return.
We are comparing our protocols to the protocols of Nova Scotia. Nova Scotia has an extensive protocol for administering IV chemotherapy. They must monitor for chemo-induced hypersensitivities and reactions as determined by the drug. They have an extensive list of drugs and reactions that they must monitor for. They must extensively question the patients for any pain or burning or any other signs of infiltration. The frequency of the assessment depends on the drug being administered. The nurses must be certified in administering chemotherapy, and they have an extensive checklist that they must go through when doing the assessment. In our case, the patient's complaints were not assessed by the nurse.
These are ways to administer chemotherapy. This is a cannula or a peripheral IV. It can be in the hand or forearm. You need to be very careful with extravasations with these types of IVs. This is what was used in the beginning of treatments with Grandma Clements, and this is where her problems began. This is a PICC line or peripherally inserted central catheter. It's a safer method to deliver chemotherapy. It's used for short-term use only. This is a central line, and these can be short or long-term. They may be tunneled or not tunneled underneath the skin, and they can be hidden underneath the patient's clothing. After they are inserted, you'll need an x-ray to confirm the placement of the catheter. And this is a portacath. This is inserted while a patient is put to sleep. The catheter is inserted into the superior vena cava and can be palpated underneath the skin. After Grandma Clements' extravasation, she got a portacath inserted in her, and she coded during the procedure.
We went over a lot of the ways that chemotherapy administration can go wrong and how some of these side effects can really affect our patients. So here are our suggestions for some system improvements. The first is the use of central line catheters or ports in the patients whenever possible. That leads to less probability of any sort of issues coming up when you are administering the chemotherapy. The second would be doing 15-minute checks on all patients who are receiving chemotherapy through a peripheral IV. This check, as noted by our nurse that we interviewed previously, should be done by a chemotherapy certified nurse so she knows what some of these side effects could look like and what to do about. Finally, a stricter enforcement of all chemotherapy infusion protocols and smaller patient-to-nurse ratios. That way, when a patient has an issue, the nurse is able to respond quicker.
And we're happy to report that Grandma Clements is cancer-free!